Hi, everyone, and welcome back to the Doc Talk. I'm Dr. Shazma Mithani.
And I'm Dr. Sheila Wijaya-Singha. How are you doing this week, Chaz?
Pretty good. Tired. I'm just coming off a string of evenings, so I'm just trying to turn my clock back around to daytime. But I have a few days to adjust before my next shift. So how about you? How are you doing?
Yeah, I don't know how you do night shifts. I used to do obstetrics and baby delivering, and I had to stop because it didn't work for me.
I don't know how much longer this is going to last. We'll see. It's getting harder.
Yeah, I can imagine. So I'm really excited about today's topic. We're diving into something that affects millions of people, but often doesn't get enough attention: menstrual disorders. So this is a general term that describes many different conditions, from painful periods to heavy periods to actually even absent periods.
And that's, as an ER doctor, it's something that I actually do see. I mean, when we think about menstrual disorders, we think, this is only something that a family doctor sees. But I often do see people coming in with severe pain or excessive bleeding, wondering if their symptoms are normal or if they need urgent care. So this is a really important topic to talk about.
Absolutely. And so before we get into the specifics, just like we usually do, let's hear a question from one of our listeners, Amy. This is such a great question, and one certainly that I see in my practice really often. So thank you, Amy, for sending this in. You're really not alone in experiencing this. Menstrual disorders do come in many different forms, and today we're going to break them down for you by diagnosis, covering risk factors, symptoms, and options for supporting you. So let's get into it.
Yeah, let's start with one of the most common concerns, which is something called dysmenorrhea, or painful periods. So, I mean, it is normal to have some discomfort during menstruation, but if that pain kind of becomes more severe, what we would categorize as severe or extreme, and it interferes with daily life, that is something that we definitely take seriously.
So absolutely. So we know that when you have painful periods, what I do in my practice is that we kind of break it down for my patients, and we go through, there are different causes of this. So it can be related to hormone imbalances. It can be something anatomical, so structurally going on in the body, like fibroids or something called adenomyosis or endometriosis. And even sort of our lifestyle and stress can contribute to how we perceive pain and experience it. And so all of these different factors can come into play, which is why it's really important to see your own healthcare provider to get a sense, because we normalize pain too often.
And that's such a good point. We really do, especially in women, we normalize pain too often. In the Emerge, I typically see people with cramping that has become kind of unbearable. So they sometimes can even have additional symptoms like nausea and vomiting. And so when somebody comes into the Emerge with severe pain kind of related to their period that doesn't improve with just typical over-the-counter medications like ibuprofen or acetaminophen, then we start thinking about other potential causes like adenomyosis or endometriosis, which we'll be talking about in a future episode.
Yeah, and I remember, Shaz, growing up, I had awful periods. And from day one of my period starting, I would miss days of school. I would have to take time off work. And it was sort of just seen as something that we had to live with. And it was so normalized, and it continues to be normalized. But that's where we want to do this and change this for you, our listeners. And please share this, because we shouldn't have to live through this kind of suffering. There are options available. So what I do in my clinic is we go through what are the causes, address the pain by getting to the root cause. Sometimes what I used to do when I was a kid, and many people do, is sort of take a lot of Advil or ibuprofen and medications that help with inflammation. But I didn't really understand why this was happening to me. And so what I want to suggest to patients, and what I do in my own practice, is again, suggest things certainly short-term things like anti-inflammatories can be helpful for painful periods. We know that anti-inflammatories can help thin the lining of the uterus, which is the blood lining that leaves every month with a period. And that itself can help to reduce pain by about 40%. But if we can also address why this is happening, that's incredibly important. So do you have a fibroid? Do you have endometriosis? Because that's going to direct the kind of care that we offer to you. And that's important to check out by doing things like investigations like ultrasounds or otherwise to get to the root cause, and then go from there. We often will use things, as you know, Shaz, I'm sure you might start people in the emerge on this, but like birth control and hormonal options to help manage pain and support them through this time. And in certain situations, I'm referring to my specialty colleagues, which again, I'm sure you're also doing when you see patients who may not have a family doctor, to refer them out to a gynecologist who specializes in this to get to the root cause and support them through this.
So Sheila, it's so important that you bring a lot of these things up because many of the things that you just mentioned do lead to menstrual health disorders. So whether it's painful periods or heavy periods, we are going to touch on all of these during this episode. Now, the one that I want to start talking about here is endometriosis. So we can't really do this topic justice as just a small part of an episode. So we will have an entire episode on this in season 2, but it would be, we would be remiss not to mention endometriosis in a episode about menstrual disorders.
Absolutely. And I think I'm glad that we're focusing a little bit on it now. We'll be having a future episode coming up that's dedicated to it, as you said, Shaz. So I'm sure you see a lot of endometriosis in the emerge.
Yeah, I often see endometriosis related with pain related to it, or people who haven't quite been diagnosed yet, or are wondering if they might have endometriosis. And so it is something where people come in with dysmenorrhea or pain. Sheila, can you tell us about what endometriosis is? Because I think it's a term that we hear a lot, but we don't really talk about what the actual definition is.
Yeah, absolutely. So when we think about the menstrual bleeding that happens, we know that there's a lining of uterine blood that leaves the body every month. This tissue, there's something very similar to this tissue that can get seated outside of the uterus and kind of land in different parts of the abdominal cavity or the pelvic cavity. So it's endometrial-like tissue is how it's defined. It's not actually the same thing as the lining itself, but it's similar to that lining, and it can land on the bladder, it can land on the bowels, it can land on the ovaries, and it can grow outside of the uterus basically and be triggered with hormonal changes, which is why on occasion some people will get very severe symptoms of pain with their periods because they're getting pain sort of throughout their pelvic cavity and their abdominal cavity. But also they can get pain in specific parts of their body, like when they're having a bowel movement. If those endometrial-like cysts, they're called endometriomas, land on the bowel or the bladder. And so you can have pain with urination or pain with bowel movements, which often is very difficult to diagnose for people. And the pain can be so severe that it can lead to things like nausea and bloating. And it often gets dismissed as bad period pain. And there's such a delay in diagnosis as a result. There's some estimates of like 10 years of a delayed diagnosis for endometriosis because it can be very difficult to actually see these endometriomas, these little cysts of tissue, on an ultrasound. And so people will come in, be treated as bad periods, and have a misdiagnosis for many years because it's difficult to actually diagnose.
And often when I see these people in emerge, it's exactly like you said, Sheila. So it's not just pain, it's these kind of like extra uterine or, outside the pelvis type symptoms. So lots of gastrointestinal symptoms that are very cyclical with the menstrual cycle. And so these patients do come in with this nausea, vomiting, diarrhea, and are often frustrated because they're still either, they think that that's the diagnosis or their doctor thinks it's a diagnosis, but they haven't quite been able to make that diagnosis and then give some treatment. So, again, we just are touching the surface of endometriosis. So please tune in season 2 because we will have an entire dedicated episode to this with an expert in the area.
For sure. And I think very, very briefly, I think there are options available, and it can be also difficult to diagnose but hard to treat. And so this is why it's so important for us to do a dedicated episode, because treatments can range from anti-inflammatories, hormonal therapies to surgery. And so we want to really do a deep dive for everybody because this is something that affects so many. So next up, let's talk about heavy menstrual bleeding. So this is also called menorrhagia. And it's something, again, that we normalize as many people experience. My own patients will come in and be like, oh, I have normal flow. And I'll say, well, what's normal for you? And they're like, oh, I go through a pad every hour. And that's not normal to go through a pad every hour, but that is how they grew up. They're like, I just grew up with this. This is what I was taught that was normal. But that's actually considered to be a medical condition, and excessive bleeding can signal that there's something else going on.
So this is absolutely something I see, probably one of the most common things after pain. So pain, like menstrual pain or pain related to the menstrual cycle, is probably one of the most common things I see when it comes to menstrual disorders in the emerge. but heavy bleeding is right up there with it. And so this is, if somebody is truly going through a pad an hour, I can often see symptoms associated with blood loss. So dizziness, severe fatigue from the anemia that's developed after these, heavy menstrual cycles. In very extreme cases, heavy bleeding can lead to anemia that's so severe that these patients need hospitalization with IV iron, IV fluids, and even blood transfusions.
Yeah. And, it's so tricky because, again, similar to pain, there can be many different possibilities or combinations of reasons why this is happening. So it can range from hormonal issues to anatomical issues like fibroids or polyps or clotting issues. So some people who don't clot in the same way as others, that's actually when I diagnosed it in my patients in their teenage years, they start having periods and they are really heavy. It's important to actually work them up to see, do you have something that maybe your blood isn't clotting in the same way? Mm-hmm. And so that's something important for our teenage listeners or for family members who know a teenager who might be going through this. There's so many different possibilities, including sort of hormonal issues, polycystic ovaries, which we're going to be doing a dedicated episode on as well. All of these things can contribute to heavy bleeding. So what do you do in the emerge, Shaz, when somebody comes in?
So often when these patients come in, there's like a few different things that we do. So, history and exam is always the first thing that we do. And so when it comes to the physical exam, a pelvic exam or a speculum exam is valuable in these cases because not only does it help me see how much bleeding there is, but it helps me see where the bleeding is coming from. And so the assumption is often that the bleeding is definitely coming from the uterus, but there are other places that the bleeding could be coming from. It could be from the cervix if there is a cervical lesion or an undiagnosed cervical cancer. It could be from the vagina. So it's important to be able to visualize that, not only to see how much blood there is, but where that blood is coming from. Blood work is important as well. So, making sure that we're ruling out pregnancy, looking at the hemoglobin level to make sure there's no anemia is important. And then, of course, ultrasound. And so ultrasound is really helpful to help visualize where that source of bleeding might be coming from. Of course, in emergency situations, stabilizing the patient is our priority. So if somebody's having such heavy bleeding that they have a low blood pressure or are medically unstable, we stabilize them with fluids, think about giving blood, and then kind of do those investigations simultaneously. Sheila, when you see these people who come into your practice, how do you kind of manage them over the longer term? Because I kind of see them in such a short, discrete period of time. What happens over the long term?
Yeah, great question. So, it really actually depends on the age of my patient too. So if they are starting out their periods, we do, and it's like really early in their life and they've just started having periods, we're working them up similar to what you had suggested there, but with looking at their coagulations, called their clotting ability. We're making sure that they're not anemic. As we get older, we look at other causes like the anatomical causes, fibroids or otherwise, and look for the root causes. And once we sort of sort that out, I work with my patients to find out sort of what their goals of care are. So if they're in the middle of a time where their fertility is something that they're really concerned about, there's certain options that we can't use. So we might give them something that helps reduce flow and reduce the bleeding that can happen, which doesn't interfere with their fertility. If they're not in the time of their life or they're not interested in pregnancy or otherwise, then we look at hormonal options like an IUD or the birth control pill or something along those lines, which are all helpful in reducing blood flow and these heavy periods. And so it really depends on what my patient's goals are, what their age is, and then we work together to find what will fit them best for their lifestyle. And there are many, many options available. For some of my patients, if we've tried these options and they still continue to have heavy menstrual bleeding and it's affecting their life, and listen, like a big part of what I talk about with my patients is also their iron. And when iron levels are low, women walk around with an iron of like 15 or 10 or less. And men walk around with an iron of like 100 to 200. And we are chronically tired and we dismiss this. This is a cause. Like we need to understand why this is happening. And menstrual bleeding is one of the main reasons why we walk around with a low iron. And we need to address that for our patients. And so once we get that, sort of figure that out, look at their goals, and then we work together to find what the best option is. And there are many, and sometimes it is a referral to one of our specialty colleagues to see maybe they need surgery or otherwise, and we go from there.
hmm So, we've mentioned fibroids a couple of times, especially in the context of heavy bleeding. So let's talk a little bit more about uterine fibroids. So these are non-cancerous growths in the uterus. They come actually from the muscle layer of the uterus, and these can cause significant symptoms. They can cause pain, but they can also cause bleeding. These are actually very, very common. They range in size. They can be quite small, kind of even less than a centimeter, or they can be several centimeters in size as well. Not everybody realizes that fibroids can actually be behind issues like pain and bleeding.
Yeah, that's right. So very common in my practice sometimes, and often people don't know that they have fibroids as a cause, which is why it's important to get that help and understand, maybe there's something that's causing these symptoms. Some of my patients come in and you can feel the fibroid actually palpably.
Okay. Yeah,
and when I'm doing an exam,
such a large one.
It's so large, or depending on where it is. So it's on the front of the uterus. I can actually really feel it. And I'm like, oh, that's interesting. That could be why you're having this. And then it triggers me to then say, let's do an ultrasound and see what's going on here. So, risk factors for fibroids include things like a family history. Certain ethnic, like folks of different backgrounds might have a higher risk. So we know our Black Canadian patients may have a higher risk of fibroids as well. Hormonal issues can also contribute to fibroid growth, because we know that actually postmenopausally fibroids shrink down. So we often know that estrogen can feed those fibroids. And so that can be a reason why we see these. But often we don't know why people have fibroids. And alongside fibroids, we also should mention, we mentioned endometriosis before, but there's another condition that's become much more well-known called adenomyosis. And that's when the glandular tissue, so the endometrial lining, the blood lining of the uterus, starts to grow into the muscle tissue. And so you can imagine that when you're having a period, it can be very, very painful. So it goes back to painful. It can cause heavy periods. And that's another diagnosis that also needs to be managed. And it's an anatomical issue. So you must see also fibroids in the emerge.
I see them pretty often. And so these are patients that often come in with heavy bleeding. And so I see them in the context of either they have already had the fibroids diagnosed and they're coming in with heavy bleeding or sometimes pain, or because I'm getting an ultrasound to investigate the heavy bleeding or the pain, I then see the fibroid on the ultrasound. And so in the context of when I see people with fibroids, it's often with heavy bleeding leading to things like anemia or dizziness. In very rare cases, they can actually grow large enough, so like several centimeters, that can cause pressure on other organs, including kind of urinary and bowel symptoms as well. And like I said, these are typically diagnosed on ultrasound. They're seen quite clearly. It's kind of the best test to look for fibroids.
That's a great point, Chaz. I have patients who often come in and we diagnose them with a bladder infection, for example, because they're peeing frequently and their urine tests are negative, and they come in, and then that warrants, like if you're having urine, like bladder infections or bowel symptoms, that warrants that next step to look at the pelvic cavity with an ultrasound and diagnose why that could be, instead of just writing it off as like a bladder issue, because it might be actually coming from the uterus, like a fibroid issue. So when we work with our patients for fibroid management, typically, it again depends on the severity. Many people go through life with having fibroids that don't cause any symptoms at all. But often people may have symptoms in the sense of like the heavy periods, pain, and other symptoms of bladder or bowel symptoms as well. So how we treat it depends on, again, goals of care and how severe the symptoms are. And so one of the things that we do is hormonal therapies like the birth control pill. If it's okay with your system and health history to be on the birth control pill, depending on where the fibroid is, we can consider things like an IUD, a hormonal IUD in particular. Copper IUDs can actually worsen pain with periods. So we tend to opt for the low dose progesterone containing IUDs. If the fibroid's not in the cavity itself, because there's fibroids fibroids can be anywhere in the uterus, in the wall, external to the uterus cavity, or in the cavity. And if it's in the cavity and large enough, it can interfere with us putting an IUD in. And all of these things can help regulate your cycles, decrease pain and bleeding. And then there's medications that we use, like the anti-inflammatories, or there's another medication called tranexamic acid that I'm sure you use a lot, actually, Chaz, in the emerge.
I use quite a bit in the emerge, yes.
And that's a big one for heavy periods that we use, that I give to my patients. I'm like, you know that you have heavy periods. These are for folks especially who want to preserve their fertility, and in the sense that it might be trying to conceive, and they take it during their periods to reduce flow. And that can be helpful. But in some cases, and especially if you're thinking of fertility and you're having a fibroid that might be impinging on the ability to get pregnant or continue a pregnancy, surgery may be the next step. And that's a discussion with our specialty colleagues like a gynecologist.
Yeah. And I think the bottom line here is if you are having symptoms that are affecting your daily life, it is really worth talking to a doctor because fibroids
Absolutely.
can be managed in all of the various ways that Sheila just mentioned. And early intervention certainly does make a big difference on your quality of life and symptoms.
So let's switch gears a little bit. We've talked a lot about like actual period pain and heavy periods, but let's talk a little bit about something a little bit different but equally important when we don't have periods. And that is a diagnosis called amenorrhea, when you don't have periods. And, for many, they dismiss that as a relief, but for some, it's a sign of something else going on.
Exactly. So, I mean, risk factors for amenorrhea or a lack of periods include things like PCOS, thyroid dysfunction, extreme weight changes on either end of the spectrum, and even high stress levels. And so we can also see situations where there can be exercise-induced amenorrhea in athletes in particular. And then, of course, for me and for you as well, pregnancy is always the one thing that we have to rule out in someone that comes in who has stopped having periods, especially if these are patients that have irregular periods at baseline. Because if patients are not having, like, typically we have a period, every month-ish, right? Plus or minus, if you're having regular cycles. But in patients that are having irregular cycles, if they're going, several months between periods, they may not actually recognize that a period has been missed. And it's usually a longer time that it takes for them to seek medical care because those are irregular periods. And so in those patients in particular, it's not uncommon for me to see them come into Emerge, not even knowing that they were pregnant because they thought that this was just a longer period without having a period because of their irregular cycles at baseline.
Such an important point. I remember in medical school and residency, that was like the way that you would fail an exam if you saw somebody with irregular bleeding or absent periods. And if you did not test and ensure that there wasn't a pregnancy happening and that is the cause, it is stuck in my brain. And it's something that we also really focus on with our residents, as I'm sure you do too, Shaz, in the Emerge, with your residents and medical students. Like, it's a really important thing because it could be something more serious as well.
Exactly.
So for folks who don't have periods, once we've excluded pregnancy as a cause, we do look to understand why this is happening. So for some folks, if it's like one period that's missed, we'll say, let's monitor it for a bit and see what's going on. If it's several periods that are missed, or you've gone a few months without having a period, we want to just check and see like what's going on with your hormones. We can do a quick panel. We might potentially do imaging studies like an ultrasound to take a look. And then we want to understand what's happening in your life. Like maybe there's something going on that's triggering this change in your life. And specifically, if it's happening early on and you don't have periods, we also need to look at things like perimenopause and menopause, which while it can start in our mid-30s, for some it starts earlier than that. And that's something that is important. And that's where we really do focus on doing a hormonal panel to understand what's happening. And then treatment will depend on the cause. In some cases may require hormonal therapy, while others, we monitor and we go from there. But it really depends on the cause.
And a reminder to our listeners that we do have an entire episode on perimenopause. So please be sure to take a listen to that one.
So let's talk about something that I think you probably see a lot. I certainly see it not in the acute phase, but you likely see it in the more like severe stage, is ovarian cysts. So this is a common cause of menstrual related pain for some folks. Some people have small cysts that resolve on their own, but in some cases they can rupture or lead to something called ovarian torsion, when the ovary twists on itself and can cause a loss of blood supply to it.
Yeah. And so rupture of ovarian cysts and torsion are two potential emergencies, and certainly things that are often, what we call a differential diagnosis. So something that's on the top of my mind when I see patients who come in with pelvic pain. And so we get cysts technically you kind of get cysts every month when you ovulate, right? But they're tiny and it's not a big deal. Sometimes the cysts can get a little bit larger. And even then they don't cause discomfort. It's usually when they rupture that they can cause discomfort. But for the most part, these do resolve on their own and can be managed with anti-inflammatories.
And what do you do when you have a larger cyst that ruptures and they emerge?
Yeah, so when we have those larger cysts, when they rupture, they can cause a lot of pain. But if they are filled with blood, so something called a hemorrhagic cyst, that's when they can become kind of more of an emergency. So if there is a large cyst that is filled with blood, you can imagine that when that cyst ruptures, it releases a lot of blood into the abdominal cavity. And so that causes this blood loss into the abdominal cavity and can make people really sick. So these patients often need admission for kind of monitoring their hemoglobin levels, observation to make sure their pain is getting better, and just making sure that that blood is not continuing to kind of bleed into the abdominal cavity. And so these patients often do need admission. And then, of course, there's ovarian torsion, which is a true emergency. And so, Sheila, as you mentioned, this is when the ovary twists upon itself and then cuts off because that blood supply is kind of leading into the ovary. And so when that blood supply twists, it cuts off the blood supply to the ovary. And as we know, we need blood to deliver oxygen, which allows tissues to survive. And so these patients typically come in with very severe pelvic pain. They're often writhing around on the stretcher. And in these situations, we really need to act fast to prevent long-term complications like infertility.
And if you suspect this is happening, what do you do in the emerge?
So ultrasound is like the most important diagnosis because it can directly visualize the blood supply, can directly visualize the ovary, and the radiologist can look for signs of torsion. And so this is something where I'm going to be calling the radiologist, even if it's in the middle of the night, ASAP, like, gotta come in, we gotta get this ultrasound done ASAP. And as soon as I mention the word torsion, like the techs and the crew are coming in to get that ultrasound done because it really does require immediate surgical intervention.
Wow. Hopefully it's not something that you see often.
Thankfully not. It is a relatively rare thing, but it is important for the listeners to know that if there is severe pain, that is definitely a reason to come into the emerge right away because it could be torsion.
Absolutely.
Okay, so before we wrap up, let's get into shift gears a bit and tackle a few common myths and misconceptions in rapid fire style. So I'm going to start, Sheila. So I will give you a statement, a myth, and then you tell me what the actual truth is behind it. So myth number 1. Intense period pain is normal.
So this is a myth. Intense pain, so pain that's interfering with your life, anything that's stopping you from doing the things that you enjoy doing or keeping you from going to work or school or requiring a lot of medications to manage, that deserves medical attention. It could be endometriosis. It could be something that we can address directly. So please do get help. So I'm going to give you a myth now. So myth number 2, irregular periods are always harmless.
So this is such a common thing that we hear. And while sometimes they're not concerning, they can signal underlying issues like PCOS or thyroid problems. So it is really important. I mean, if you have a one-off irregular period, it's not a big deal. Or if you have an underlying diagnosis already, then you would expect it. But it's not something that is normal. It's not always something that's not a big deal. So it is important to get that investigated by your doctor. Okay, so myth number 3, you can't get pregnant during your period.
So while it's less likely, pregnancy can still occur if ovulation happens early or if there's sperm that survives, because sperm survives for several days and it can stay in the reproductive tract and you can get pregnant. Although it's rare, it is possible. So myth number 4, tampons can get lost inside your body.
I can't tell you how many times I've heard this myth. And for some reason, it still gets perpetuated to even now. So no, the vagina is a closed end structure, meaning that there's an end to it. The tampon can't travel beyond the cervix. If it is difficult to remove, because that is something that people come into the emerge with, where there's a tampon that's stuck, gentle maneuvering. Yeah, for sure. And so gentle maneuvering will usually work. But of course, if you cannot get your tampon out, then it is important to see a doctor. Mm-hmm. Myth number 5, birth control will mess up your hormones permanently.
So this is not true. Most people's cycles will regulate after stopping birth control, although it can take a little bit of time to kind of get back to your previous cycles. And so this is really important to debunk because people will not take it for this reason, and it's not a valid reason to not take it. Myth number 6, only teenagers experience irregular periods.
So although cycles can be irregular as you start your period, so menarche, like when you get your very first period and then start kind of settling into a cycle, irregular cycles can actually occur at any age due to things like stress, hormonal changes, or underlying conditions like PCOS or thyroid disorders. So it very much can occur at any age, not just in teenagers.
Very true. So we hope this episode has helped you understand a little bit more about menstrual disorders. I feel like we could deep dive into each and every one of these topics, Shaz. So, certainly something that we'll look into. And if this is really something that resonates with you, please do write to us and let us know. We encourage you to prioritize your health and really advocate for yourself, because if you're experiencing painful, heavy periods, or you're worried about this for yourself or someone you love, people have been dismissed in our healthcare system when it comes to menstrual disorders. And we really encourage you to seek out that support because you deserve care.
And that leads us to our prescription for today. If you are dealing with symptoms that impact your daily life, you do deserve care. Don't hesitate to seek medical care because early intervention can make all the difference.
So thank you so much for tuning in to the Doc Talk podcast today. And don't forget to send us your questions. We really love hearing from you.
Thank you to everyone for tuning into the Doc Talk today. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your own personal health needs. And of course, please be sure to follow us on social media at the Doc Talk Pod and send us your questions.
This episode is brought to you by Always Discreet. Our patients often share that if they sneeze or laugh too hard, or even during a workout, they can be bladder leakage. There's no shame in this, and there are solutions. You're not alone, and there's no need to worry. Always Discreet is here for you. Many experience urinary incontinence as they go through perimenopause and menopause. Nearly half of us may encounter leaks or accidents during this time. And by age 65, about 70% of women report experiencing some form of urine leakage. Yet, it's topics that we rarely discuss.
Always Discreet's Rapid Dry Core locks away even the biggest leaks with no wetness, no odor, and no visible lines, allowing you to stay active and confident. They stay in place comfortably and remain invisible under clothing. Check out the link in the bio or in the description for an Always Discreet coupon and step confidently into this new chapter. Always Discreet, your dependable solution for bladder leaks.